Welcome back to Falcon Physician Review's online review for USMLE Step 1. This is Microbiology Module 21. We'll be discussing Mycobacterium leprae and the clinical presentations for leprosy. We'll also talk about mycoplasma and the diseases it causes. Welcome back to Falcon Physician Review's online review for USMLE Step 1. This is Microbiology Module 21, Mycobacterium leprae and mycoplasma. Mycobacterium leprae are acid-fast rods, and they're obligate intracellular parasites. Leprosy is caused by Mycobacterium leprae. It's also called Hansen's disease. It's a chronic disease that's featured with massive disfigurement. Fortunately, it's rarely seen in the United States, but it is common in the Third World. India, Nepal, Brazil, there are millions of cases. It infects the skin and lives at low temperatures. Transmission for Mycobacterium leprae is through nasal discharge from untreated patients. The pathogenesis involves infecting the skin, and it has an affinity for peripheral nerves. This table features the difference between the two clinical types of leprosy, tuberculoid leprosy and lepromatous leprosy. The key underlying difference between the two types is your cell-mediated immune response. If you have a strong cell-mediated response, you're going to have tuberculoid leprosy. You're going to have a positive lepromatin skin test. You're not going to have very many organisms in the tissue, and you're going to have fewer lesions, less enlargement, and less paresthesia. If your cell-mediated immune response is not strong and you form more of an humoral or Th2 type response, you're not going to be able to kill these intracellular organisms. Therefore, you're not going to have enough immunity to have a positive lepromatin skin test. You're going to have lots of organisms, and you're going to have lots of damage. Okay? These are the people who lose fingers and toes and have the huge disfigurement. Clinical findings of leprosy include ulcers, resorption of bone, and most of these features are worsened from careless use of hands. Basically, they can't feel their fingers, and so they don't know it if they're sitting on a hot stove. They don't know it if they slam it in a door. They have destruction of their nerve tissue. That leads to destruction of their hand tissue. Lab diagnosis for leprosy is difficult. You can do skin testing for lepramin. You can do acid-fast stains from skin biopsies, but it's not culturable, so you're not going to be able to grow it. Mostly, leprosy is a clinical picture. The treatment includes dapsone and rifampin. You can also treat with clofazimine if you have lepromatous leprosy. Let's do a question. A 22-year-old missionary returns from Africa for evaluation of areas of skin hypopigmentation. You perform a lepromin test, which is positive. The causative agent of this patient's disease has an affinity for which of the following? So we talked about how it grows in colder temperatures, loves the skin, and likes the peripheral nerves. We haven't talked about leprosy affecting the lungs, bone, liver, or brain. And so the answer is D, peripheral nerves. You could argue that bone is affected in leprosy, but that's usually secondary due to nerve loss and physical damage. Next up is atypical mycobacteria, including the Mycobacterium avium complex. You'll see infections with Mycobacterium avium in higher-risk patients, such as those with HIV or AIDS, COPD, cystic fibrosis, and bronchiectasis. These mycobacteria are frequently found in water, plants, and soil throughout the environment. Mycobacterium avium is much less virulent than Mycobacterium tuberculosis, and so you have to be immunocompromised in order to get infected with it. Like we said, Mycobacteria tuberculosis infection will infect healthy people, and more so in AIDS patients, at an earlier stage of disease, and they can have atypical pulmonary disease, and extrapulmonary manifestations are more common. The acid-fast filamentous bacteria include Mycobacteria. They are all aerobes, they don't form granules, and they are all acid-fast, as this table shows. Mycoplasmas are different from Mycobacteria. There are 4 species that you'll need to be familiar with: Mycoplasma pneumonia, hominis, genitalium, and the associated ureaplasma ureolyticum. These are the smallest free-living bacteria known to man. They are facultative anaerobes, except for Mycoplasma pneumonia, which is a strict aerobe. They have no cell wall, and they require cholesterol for growth, which differentiates them from most bacteria, and they're also different from the mycobacteria. Their pathogenesis involves adhering to epithelial cell surfaces, both in the respiratory epithelium and the urogenital epithelium. They cease ciliary movement and inhibit the host's ciliary sweeping movement to clear bacteria. They then damage the respiratory epithelium and cause tissue necrosis. This table highlights the 4 main species and the diseases they cause. This will be a good one to remember. It's pretty simple. Mycoplasma pneumonia causes upper respiratory tract disease, such as atypical pneumonia. It's a common cause of atypical pneumonia. M. hominis causes myelonephritis, pelvic inflammatory disease, and postpartum fever. Mycoplasma genitalium and Ureaplasma ureolyticum both cause non-gonococcal urethritis. Mycoplasma pneumonia causes pneumonia worldwide, and it has no seasonal variation like other pneumonias do. The transmission for most respiratory illnesses is through aerosolized droplets and close contact. Clinical findings include a long incubation period of 2 to 3 weeks. These people have non-pulmonary symptoms predominate, such as fever, headache, malaise, but they also have a persistent non-productive hacking cough. You can get bullous laryngitis, cold isohemagglutinins, and the chest x-ray is often worse than the signs and symptoms. Lab diagnosis for mycoplasma includes a fried egg colony on mycoplasma or Eaton's media, which has cholesterol which mycoplasma requires for growth. It also has a good complement fixation test, which is faster than colonization and growth. Treatment includes macrolides and doxycycline. As we know, it has no cell wall, so penicillins and cephalosporins, or antibiotics that target the synthesis of peptidoglycan, are not going to be effective in this organism. Let's do a question. A 20-year-old college male presents with a 3-week history of a persistent dry hacking cough, sore throat, and malaise. Chest x-ray shows bilateral streaky infiltrate. Gram stain of the sputum is inconclusive, but serology is positive for cold agglutinins. Which of the following antibiotics would be most appropriate choice for this patient? So this is a textbook example of an atypical pneumonia. Mycoplasma is classic here. It's going to be your first thing to think of. You've got non-pulmonary symptoms predominating, you have a non-productive cough, you have a non-productive sputum sample, and you've got cold agglutinins. So you know it's mycoplasma, you're going to treat with erythromycin. Ureaplasma ureolyticum is a frequent cause of non-gonococcal urethritis. Urethritis from gonococcus is frequently purulent with associated lymphadenopathy and pain. Non-gonococcal urethritis is less purulent with a kind of a clear discharge that's frequent and less painful. Mycoplasma hominis can cause pyelonephritis, pelvic inflammatory disease, and postpartum fevers. Lab diagnosis includes culture. Treatment is doxy or erythromycin. Let's do a question. A 38-year-old HIV-positive female with a CD4 count of 52 is evaluated for a new onset seizure activity. On physical exam, you note left-sided weakness. A CT of the head identifies a 4 cm ring-enhancing lesion in her right parietal region. Aspiration of the lesion reveals a weakly acid-fast aerobic gram-positive organism. The causative agent is... This is something we haven't necessarily talked about in this module, but it's good to mix things up. With HIV-positive patients, they're immunosuppressed, especially with a CD4 count of 52. So they're prone to opportunistic infections. If you have a cerebral lesion with a 4 cm ring-enhancing lesion that grows gram-positive organisms, you're going to think about Toxoplasma gondii. Next question. A 43-year-old homeless male with AIDS presents to you for evaluation of a 2-month history of a 10-pound weight loss, fevers, cough with productive foul-smelling sputum. Sputum shows gram-positive organisms with sulfur granules. Appropriate treatment for this organism includes... Now, up until a certain point, we could have had a lot of things with an AIDS patient with cough and B symptoms. By the time we get gram-positive organisms and sulfur granules, that's the key to getting this question right. We talked before in a previous module that if you ever hear sulfur granules, you need to think of actinomyces. Actinomyces is a gram-positive organism that can cause disease. It doesn't have respect for tissue planes, and you're going to see it in immunocompromised patients. It's treated with penicillin and surgical drainage. You need to get air to the tissue for this anaerobic organism. Next question. A college freshman presents for evaluation of a 3-week history of cough, low-grade fevers, fatigue, headache. Chest x-ray shows diffuse bilateral infiltrates. Lab tells you that the blood sample you set for evaluation is cold agglutinin positive, which of the following would be appropriate therapy for this patient? So again, we have a situation where we have an atypical pneumonia. We have a young patient, and they have non-pulmonary symptoms predominate, and we have cold agglutinins. So we're going to treat this patient who has mycoplasma pneumonia with erythromycin. Let's wrap up Module 21 for microbiology. We talked about leprosy, its two clinical presentations, and how the host's cellular response, the immune response, dictates which presentation the patient has. You should be familiar with somebody who's losing their joints, has hypoesthesia, and has risk factors for leprosy, and you should know how to treat it. Finally, the mycoplasma species are interesting. They cause unique diseases, including UTIs and pneumonia. Mycoplasma pneumonia, you'll need to be familiar with the treatment and presentation of somebody who's 15 to 50 with an atypical or walking pneumonia. Up next, we're going to talk about the spirochetes in Module 22.